Uh, mm. Hello, everyone. Welcome to CTeL's new webinar series to address the use of digital health technologies in combating the opioid use epidemic. My name is Krista Natoli, and I'm CTeL's Executive Director. For those that are new to CTeL, CTeL is a 501c3 nonprofit research institute focusing on all the laws, policies, and regulations impacting the delivery of virtual care. We have 3 subject matter areas of focus that fall within CTeL's wheelhouse: telehealth, remote monitoring, and artificial intelligence. With us today, we have Ellie Gordon, President and Founder of Behaivior AI, and Matthew Rumbaugh with Gateway Rehab. We're going to hear a story from both of them on how you could use digital health technology and being able to help and support patients that are going through substance use disorder. Matt?
Well, good afternoon. So we're starting with me. Jump right in. I'm good to dance really quick. So like I always say, I put a couple slides together not to overburden this. I think we have like 10 minutes each. And again, I'm talking to a group of really smart people. So let me see if I just need 1 second to share my screen to see if I can pull this up for you all. Do you have a sec? Just let me.
Sure.
Oh, sharing's not turned on. I sent you the deck, Krista, if you want to pull it up.
Sure, of course. April, turn on the sharing capabilities, but I could also pull it up.
Yeah, if you pull it up, then I'll just say next slide, next slide.
1 moment.
Sorry about that.
No problem.
So, as all of you know, I represent Gateway Rehab. We are in behavioral health and SUD space. I'm the director of Telehealth. We're a nonprofit organization with probably around 60 or 600 employees, 25 total outpatient facilities, withdrawal management, halfway houses. We're one of the largest recovery groups in Western Pennsylvania, and we've expanded our reach through the pandemic and post-pandemic through telemedicine. But again, you've all heard me talk before. I've heard you all talk before. I think some really interesting things are happening right now. And how we can equate it back to something that's important to us is what the DEA is doing right now. Now, we prescribe buprenorphine, and we know that, you know, the controlled substances and some of the relaxations are going to be pulled back to special registries, this possibility of checking all PDMPs throughout the United States. So they were looking for guardrails. And there I can see my, that's the 3rd slide. So if you want to go up, yeah, just go to the front one. So I basically just said all this stuff about what we've been doing, but I've been at 2 or 3 of the meetings that we've had in DC, and I also support Ellie's team because of what they bring to the table with their AI. And the biggest thing, and I don't want to take any thunder away from her, that craving prediction AI is a huge tool, and getting that integrated into our platform is going to be super huge. So if you go to the 2nd slide, I always like to start with something kind of funny. So this is a behavioral change stat. And if some of you saw it, in 2022, that they asked hundreds, thousands of people what was the first thing that they did in the morning before they got, once they got out of bed. And you can see they check text, read email, post on social media, and check calendar. But I really, really love what we were doing in 2002. If you notice, 97% of them were actually utilizing that little rubber ducky and below that. I don't think we were texting. I don't think we were checking our social media, but that statistic is something that really stands out to me because I'm like, in 20 years, technology changed a innate behavior that we've been doing since we've been upright walking. And it's just something that we know. So change, crisis management, innovation comes through, but the technology that's in our hands, the technology that we can integrate with to touch our patients and restore our patients and know that we can make changes through these devices is impactful to me. So I always like to throw this slide out. I love it. Because I bet you if we ran a news survey right now, 97% of those people that are using the restroom are probably checking email, posting, and doing other devices while they're sitting there. So let's go to the next slide. Something I want to talk about today that's going to be really important. We've integrated an enterprise level telehealth platform here that allows me to be fully integrated with my EHR, allows me to have applications that go out, native applications that go out to our patient population where we stay connected with them throughout the day. They're able to be dialed in, texting, encrypting. Their video appointments are scheduled for them. Their care teams are associated with them. Alerts go off, and we can stay dialed in with them. But what we've done is we've built out this stewardship. It's a program. We've always had a stewardship around opioids and stewardship around how we prescribe. But what we did was we connected and partnered up with a company called OptiSafe. And basically what that is a prescription drug monitoring platform, which brings automation immediately. So you need to have the platform, you need to have an EHR, and you need to have everything fully integrated. Considering what the DEA is doing right now, and we're hearing all this stuff that's going on, pulling back on the restrictions, adding a special registry, PDMPs having to be pulled from all over the country now, each individual states. These guardrails ensure some safeguards that they're asking us to show them in advance, like what we're going to do. So here's how it works for us. In one click, GRC can seamlessly integrate into our EHO workflow, making it easy to ensure the providers comply with any of the state laws the DEA has and the federal laws. But we can pull from multiple data streams, including the PDMP, tox reports, and other patient data that goes into the EHR and interpret that in seconds. We obtain full and current opioid history of the payment of the patient, that PDMP and the tox report. We generates patient risk stratification for patients on opioids and identifies appropriate interventions. It assesses and records the patient's pain and function levels, and we adhere to the CDC opioid prescribing guidelines at individual patient populations. We are a nonprofit facility that is invested into an enterprise platform that allows us to put these guardrails in. We are not a total online facility, but we understand the importance of a hybrid model. And these are the guardrails. And by having the foundation, having the platform, and then being able to partner up with companies like OptiSafe and what Ellie's going to talk about, allows us to fully integrate into our systems easily so that we can do it. So in light of what the DEA is doing, here are some additional guardrails that we have, because typically when you pull a PDMP, that's all you're pulling. You're not getting all those other resources in seconds. Next slide, please. I think we're still frozen on that slide. Is everybody seeing the next slide? All right. So what our providers see, it's real-time on the clinician decision support tool for controlled substance in one single dashboard that's integrated into my platform, also integrated into our each EHR. So patient risk profile for misuse or overdose, recommendations and guidelines and best practices, recommendations based on the patient's risk and the prescribing of naloxone. We also see the patient risk on the other side, recommendations for best practices. But the other thing was from the PDMP. It looks like I put two of the same back to back. But this platform ensures additional guardrails around our prescribing habits that becomes fully holistic around the patient. Okay, we prescribe it. Do they fill it? And then when they're coming in and they're seeing us and we're doing urine tests on them, we can see if they're using the medications and not using medications, and then we can pull all the data into one place. That is something that we are currently doing, and as a demonstration site with OptiSafe, we're looking to be able to take this to the next level because we're seeing adherence and compliance very much so on the rise. But we must follow our patients and stay dialed into those patients so that we can then start chipping away at some of the other factors. Millions and millions of dollars go through EDs every year and every day for treating patients that are overdosing. It's just blowing up. People are dying, and we can start implementing this to look back at what is the cost to the system, what's the carve-outs to the system, what are overdose rates, and by us being connected like this, we can then connect and associate with our partnering hospital systems that really aren't prescribing. They're not prescribing the first dose for them. So our bridge clinics can immediately get a patient who's in the throes of withdrawals to get in touch with us. We'll do an assessment, an evaluation right off the bat, and get a bridge script to them that can maintain them for 2 to 3 days to then determine withdrawal management or intervention. And that's all I wanted to share with you guys today. I know I went over my 10 minutes. I hope those slides give you a better picture of what we're doing as a safeguard and something that we have no problem talking to the DEA about.
Thank you, Matt. And then can you, Nick, can you give Ellie the ability to share her screen? And then Ellie, just as an FYI, you are still on mute.
Hello, can you all hear me all right? And you can see my screen? Great. Thanks, Matt, and to the CTeL folks as well for sharing about these opportunities that we have to help individuals and also provide the opportunity to share about that. I'm Ellie Gordon. I'm the founder and CEO of Behaivior AI, and we're on a mission to provide accessible mental health and addiction support using our tool Recovery, which is an AI-enabled behavioral health technology and wearable platform for crisis aversion and mental health support. And I want to tell you the story about how we came up with this to help people struggling with OUD to be able to monitor them and provide support in place. So we got started in 2017 in Pittsburgh, PA, as a part of the IBM Watson AI X Prize competition to solve a global grand challenge. And our community has been so hard hit by the opioid epidemic. We've lost loved ones and had our struggles, and we knew that we couldn't just let people struggle and die without support and tools. And we knew that there was a way to help mitigate this. So we used our lived experiences and creativity and brain power to work with experts at universities and receive funding support from community organizations, universities, the National Institutes of Health, National Science Foundation, among others, to help develop a solution. And some of these stats I'm going to share, you already know, but I'll just go through them quickly in case any of you need a refresher. So last year, over 300 people died every single day from drug overdoses, with higher than ever annual deaths exceeding 110,000 people. And as the leading cause of accidental death, the annual cost of addiction is $800 billion in the US alone. And current treatment models are reactive, inefficient, and expensive alone. So the costs of addiction and poor mental health are huge global crises. And The recurrence of use often leads to a costly downward spiral that includes lost productivity, diminished quality of life, criminal justice, and healthcare costs. So this significantly impacts all of us, regardless of whether or not you or someone you know is battling with these struggles. Another element that's not always considered is the high prevalence of untreated substance use disorders in the US, and these lower workplace productivity, and they have high employer costs. And as we're dealing with the opioid epidemic and worsening mental health crises, we have a clinical workforce shortage, particularly in behavioral health. So people are going to rehab, they have coverage for 30 days, and then they go home. And most returns to use and overdose actually occurs during those care gaps when substance use tolerances have been lowered and their support is often slim to none. So we have to safeguard these patients from overdose if they have a weak moment. And our tech allows the patient, regardless of where they are, to have that safety net underneath them. So one thing that we can all do as well is to help improve access to and reimbursement for this technology. And there are patient populations that are very much underserved as well. I'll share a little bit more about our tool. We have a platform called Recovery, and it's a AI-enabled behavioral health tech and wearable platform. So it uses a mobile application and smartwatch typically to support individuals. And then we have a web dashboard for care providers or care managers for crisis aversion and mental health support anywhere along the continuum of care. That's something that you have with you regardless of where you are in treatment process. And care providers or care managers can use Recovery to know in advance when their patient pursuing or in recovery is in a high-risk state and vulnerable to a crisis event, such as a return to use. And then we provide real-time interventions. So individuals not only have insights into what's going on in their own bodies, but they have the connection to individuals in their support network to provide alerting and crisis support so we can save their lives and help individuals live better lives, and then also help to mitigate some of these issues that care providers are facing. We take a person-centered approach, which is critical. So it's personalized. It doesn't matter if you're a person who works on Wall Street or a person who is coming up to pick up your trash every week. Everyone has high quality support, and that's something that is critical, especially these days, as Matt was mentioning, where we rely so heavily on these applications and they personalize things for us. Our healthcare needs to be personalized as well, and that improves outcomes. And for applicability to care providers and care management, we use a passive monitoring system that has the potential to leverage our care providers' limited time by synthesizing real-time user metrics like sleep and stress and emotional state to understand and then address the drivers of substance use and mental health crises. So we use these tools together with AI. These are high-level technologies, but they are accessible to anyone. And like Matt mentioned, we have these amazing tools, not only in the care provider setting, but in the hands of individuals. And it's incumbent upon us to help bring these tools to individuals and provide awareness to the decision makers who are making decisions that can exacerbate these overdoses and mental health crises, leaving people without the care that they need. We have an evidence-based tool been validated by clinical studies, improves outcomes, and is significantly cheaper. We have a number of value propositions for all these folks, and you can feel free to reach out if you're interested in learning more. And we work with individuals in the community to receive the support. We all need to work together, and by working together to help change these things, we can hopefully make some impacts. Thank you for your time.
Thank you so much, Ellie and Matt. One of the reasons we really wanted to showcase Ellie's technology and Matt's real life experience working in these clinics and seeing patients on the front lines is because there is this narrative right now with DEA that there is concern that there are not guardrails in place to actually monitor patients that are recipients and users of these types of medications. So we wanted to highlight the fact that the industry has really impressive safeguards in place and they're already being implemented. I want to pause here and see if there's anyone that has any questions. Well, we're going to continue to putting together these types of speaker series every week on DEA issues, and we'll continue to update you on information that we receive from our contact, Scott, and hopefully try to keep information flowing to everyone that is interested in needing information on what the prescribing of controlled substance is going to look like post December 31st. But it's we've shared this with Matt and Ellie last week and on the webinars, there's a lot of misinformation. So if you have any questions, please feel free to reach out. There were a couple articles that said that you can't prescribe Schedule 2 unless you have, you can't prescribe Schedule 2s and all the other schedules unless you have an in-person examination. That was misstated in an article. So please feel free to give us a call if you would like clarification.
Krista?
Yes. Joe?
Hello?
Yes.
Hi. I apologize for being on the road. I hope the road noise is not too nasty. Also, of course, I couldn't see the slides. And on top of that, the connection wasn't fabulous. But I understand, I'm hoping that you can correct or verify that one of the features of the technology is the ability under recovery to determine in advance that a given patient is likely to deteriorate as a result of cravings that become irresistible at a certain point,
Right.
And that it can be done in advance.
Mm-hmm.
So the first question is, am I right about that? And then second, how is that possible? How is that done?
Thanks, Joe. So we do cravings prediction, and this is 4 to 6 hours in advance. So what we do, and if any of you are interested, I can at some point later you can connect with me and I can share our tool and show you how it works. But we pull, it's primarily physiological data. And we worked with, initially when you first got started, a lab at Carnegie Mellon University. They had done prediction models, successful prediction models for binge drinking, predicting that in advance. So when we first started, we worked with this lab to adapt this strategy for opioids. And with the physiological data that we're pulling from these devices, we have AI models, and they're individualized per person. And when someone's in a high risk craving state, we ping those individuals so that they can receive support. Those are critical time points when we're not just responding to overdose, but we're taking a proactive approach. And that is critical. You don't want to have, in the US, our healthcare system is very, very much putting a Band-Aid on things and responding to crises. And we have the ability to take this proactive approach. So when we detect those high-risk craving states, we give people hours in advance to reach out to their care provider. We also send alerts to care providers and support networks so that they can help individuals to intervene if an individual isn't able to take steps on their own to use coping skills. Our interventions are things like breathing exercises and mindfulness and connecting to their community members. And but our physiological data is incredible. I was just at the MHSRS conference. I spoke there at a session that is a military health symposium, and we learned about all these incredible technologies using people's pupils to predict things and create diagnoses. Typing differences in typing can indicate a lot about individuals. We have incredibly powerful technology tools. We created one of those tools and we want to get that out there. One of the strange challenges is that we thought the hardest part would be developing the technology. And the hardest part is actually having broad deployments of technology. Matt's doing an incredible job with that. CTeL is doing an incredible job of advocating, but we have a lot of healthcare providers that are resistant to technology use. And of course, these systems with insurance and these regulations that are creating these barriers. We have the tools and we need the support from these other stakeholders to bring these tools to the individuals that they serve. And they lower costs, they reduce these risks, and they can help to mitigate these problems that we're facing.
Thank you. I'm particularly interested in the physiological data that are useful. You mentioned two. One was the pupils. I'm assuming you're referring to the diameter of the pupil?
We don't use that, but there is one of the many fascinating talks at the conference one of the sessions that was for diagnosis of PTSD. So they have a smartphone set up in front of them and they use the camera and then it creates a PTSD diagnosis and they have, like us, clinical validation.
Okay.
Yeah, we are looking at things, heart rate, stress levels, movement, and all of these factors play a part.
How do you assess stress levels at a distance?
So there's actually been many decades. Yeah, we send alerts for high stress levels as well. And we've built on decades of prior research that have created all these steps along the way, which is the beautiful part of our scientific community, where we build on the work of prior researchers who have been looking at things like, how does heart rate and HRV affect stress? How does movement affect this? And so with all the talented individuals that we've worked with, we have built upon this research and pulled that research into our models. And these are all evidence-based and clinically backed.
Is blood pressure one of the parameters? Respiratory rate? I'm just trying to get a handle on what the magic data are, the ones that actually enable you to predict the craving problem.
Ellie, I could speak to, so Joe, one of the indicators for us when we monitor our patients is, and even on our inside, blood pressure, think about heart rate and respiration. If I have a baseline, right, and you've been with me and I'm collecting these baselines, my current platform right now will give me, if we're watching those baselines and heart rate or respiration go up or drop down and they're outside of the variables, so, maybe they went out to do a 10-minute walk or whatever, just having that alert to alert the care member on the back end could be the difference of, did the patient fall off and make a mistake? Did they ingest something? Did they do something that they shouldn't have? If we know we're prescribing these medications and then all of a sudden the collection of that data goes out of one of those thresholds that we have baselines on, we are actively going to want to react to that, because that could be, a patient could be in overdose status or distress status. Because remember when Dr. Diallo talked to this group a long time ago, it's not like a diabetic. If our patients make a mistake, it can be deadly because there could be fentanyl. But when you're talking about what Ellie's saying, cravings and predictions that fall into the background and what they're built on, she can talk into that a little bit. But if you give me 4 hours of give my staff 4 hours in advance, that makes a difference of that patient making a decision to go this way or go that way. And you can't see me right now. They're decisions, because when you're in a state of withdrawal or you're in a state of finding Jesus, you make 2 different decisions. And we know immediately if I can get a script to them within an hour or two, we can get them under control so they don't make the wrong decision. Sorry, Ellie, I know you were on mute, but I just wanted to jump in there because he's talking about other biometrics, and those biometric markers for me indicate something is going on with this patient, alerts us to get in touch with them. We're not pointing the finger at what's going on, but we're getting eyeballs on them.
Well, you all stop me if I'm monopolizing things unduly. I don't want to be disrespectful of anyone else. But what I'm particularly keen on is the identities of the physiologic parameters that you monitor in a manner that allows you to make the prediction. I understand the value of the prediction. I understand that this is based on prior work. That's fine. What I understand so far is blood pressure, heart rate variability. Are there any other parameters that are pertinent to making the prediction?
Yes, we use a plethora of sensors that are on these devices. So it's there are some predictors that have greater impact, and there's some that have a lesser impact. We individualize the models per person because for some people, some elements have a greater impact or a lesser impact. And like Matt was mentioning, we use that baseline. They're not necessarily something it's easy to explain on a phone call, but they our bodies and the sensors and what they indicate are very powerful things that luckily we are learning more and more about to use to make things better for us and our health.
Okay. Well, thank you. I've taken a lot of your time. I appreciate it.
All valid points, Joe. All valid points. I will say this. Ellie's company is the first one that came with me with scientific data, the work they did with the VA and the work they did over at CMU, that I scrutinized and dug deep with them on some stuff and actually submitted some applications so that we can do some more work with them. I can tell you this. It's the first one that I've seen with the craving prediction that I'm gonna lean in on them a little more than some of the other ones that are out there. But I think, Ellie, to his point, having those type of answers up could help the general audience understand it a little bit better.
Thank you. Do we have anyone else that has questions on this? All right. I see some new faces here, so thank you so much. I sent you a message directly. I'm just going to put my calendar in here if anybody wants to grab some time, talk about this or DEA waivers that are expiring.
Hey, Krista, somebody put in talking about what we can do collectively about the changes in policies. Is that what you're referring to? What we're doing right now for the DEA?
I'm sorry, I don't see that. Did they send it directly to you? Would you be able to read the comment?
It just said, can you talk about I think what they're saying is what we need changes in policy. Somebody put that out there.
Oh, okay. So I guess, one of the questions that maybe is being presented here is DEA going to inform us? CTeL learned last week, we had a presentation with Scott Briggs, who literally just retired from DEA after 30 years and was chief of the draft rulemaking committee. He let us know that DEA is likely going to let the waivers run out. It's very complicated political dynamic there, but DEA had a proposed rule that it was going to issue. It did not receive approval by OMB because OMB received a non-concur from HHS. All of that is political jargon to say that there was a proposed rule. It got a thumbs down from HHS, who was part of the draft rulemaking. And as a result, on the Federal Registrar, you would see that they were supposed to come out sometime in September with a draft notice of proposed rulemaking for special registration and then also the prescribing of controlled substances. It doesn't look like we're going to get that. And DEA doesn't have a timeline or deadline requirement to act before December 31st. So what this means is that we are likely going to revert back to pre-COVID standards. So if your system or anyone that you're aware of is prescribing controlled substances, we need to get them on the line, let them know that they need to quickly pivot, because there are penalties that follow if you are prescribing controls inappropriately, which would be via telehealth as of January 1 into the home, using direct-to-consumer telemedicine. That's really important. We have more updates on the additional guardrails, and we're going to do another webinar next week. So if anybody has any questions, I put my Calendly in there, and happy to talk more. Yeah, so thank you, guys. Thank you to Ellie and to Matt, and thanks for bringing, thank you for bringing so much publicity and recognition to this issue.